Hello, hello everyone. This session. I really would like to thank Dr. Shailesh sir, Dr. Ramkrishna sir, everyone for taking the lead to we are so benefited by all these lectures, especially not just reading, especially this branch. No one else can take that. No one else has the liberty to say that they study so much as much as neurologists do. And as long as we can keep updating ourselves, it's the best thing. One important thing why we divided me and Korean, we divided this lecture series was because we wanted to basically make sure that every neurologist does not become, does not uh, have to depend on a radiologist to read the scans, to understand the basics. It is very important for us to understand how or why different sequences in the MRI happen, and based on that we can learn to read the scans. Next session we'll be discussing the clinical aspects, but this entire session will be on different sequences of MRI. As far as what we have seen in the exams, the most questions do come on, they end up asking about the different sequences of MRI, and hence we thought that we should cover this first. Basically, how did this MRI begin? When we see the whole concept post the World War II, post the World War II, what happened was, once the atomic bomb was dropped, it was the word nuclear was such a dangerous concept. The word nuclear had such drastic it had such drastic change. Sorry, should I say it had such drastic devastating this thing on everyone, that the medical aspects of the nuclear physics was seldom recognized. But in 1953, for their work in Mr. Felix Bloch and Edward Purcell won the Nobel Prize in Physics because of the concept that they discovered called nuclear magnetic resonance. It basically meant that every nucleus with an odd atomic number has a charge and a spin. Based on the spin, we will be able to identify the signal coming out of it, which I'll be discussing. If possible, take this whatever doctors we are is because of the teachers who have taught us. Whatever we are is because of what we teach. We need to know where we have come from to understand where we go to, where we are headed. On the midnight of the 2nd of July 1977, on the midnight, this person called Larry Minkoff underwent the first MRI scan on the midnight of July 2nd, and it took close to 4 hours and 45 minutes to take this one image. This began at midnight 12 a.m. and at 4:45 a.m. the next day morning, they found this image of his chest at T8 level. Imagine how much we have come forward today. Do we even think twice about when we order an MRI about where we have come from? Our teachers came forward, our teachers learned their neurology through myelography, through X-rays, and now today they when they teach us about MRI, it is indeed a pleasure, but we should know where we have come from. The concept to move, I really would like to emphasize, I begin all my lectures from history. This concept, the shift from the word nuclear magnetic resonance towards denuclearizing, towards making it a magnetic resonance, came from this man, Dr. Raymond Damardian. He published a paper on the February 8th, 1974 itself, that these could have been detected early. But it is so sad that I would request all the residents to please make sure they know these two names, because they ask it in the exam. It was Paul Lauterbur and Peter Mansfield who won the Nobel Prize in 2003 for the discovery of the MRI. But it was sad that they forgot to mention David Damardian. But it was an honor that the New York Times made on the 20th of October, following the announcement, gave a headline saying it was a shameful wrong that must be righted by the Nobel Committee. He said, Damardian said, if I had not been born, Would MRI have existed? I don't think so. If Latabier had not been born, I would have definitely got there eventually. It is sad that he didn't win the Nobel Prize. Now, coming to the very quickly from moving from the physics, moving from the basics, we go on to the physics. Now, coming to simple class 12 physics. First, we all know a simple atom has three components: a nucleus, which consists of a proton, which is a positive charged, and a neutron, which is null charged, no charge. And it is surrounded by layers of electrons, which are negatively charged. Electrons have no mass. Hence, the entire mass of the atom comes from the nucleus, which has a proton and a neutron. The nucleus is positively charged. Hence, for all practical purposes, the simplest atom that we know is a hydrogen atom. A hydrogen atom has a single proton in its nucleus and a single electron. Now, if we go back to the concept of nuclear magnetic spin, nuclear magnetic resonance, we need to know that every charged atom with an odd number charge can generate a magnetic field around itself on its own. Every atom. Now let's just take this atom, for example. It will have a magnetic field around it. Now, there are so many atoms in our body, so many trillions, gazillion atoms in our body, all of which are rotating in their own direction, all of which are generating magnetic fields in their own direction. Hence, our normal state is a state of chaos. But we need to put that in order. That is the concept of nuclear magnetic resonance. We all have seen this picture. We all know Fleming's right-hand rule. We all have passed class 12 and come to MBBS. We need to know this basic thing. The direction of current produced is perpendicular to the magnetic field generated. This was the same from the Ampere's law. When the magnetic field is rotating in a circle, the current produced will be perpendicular to the direction or the plane of the magnetic field. We are all basically magnets. The human body is made up of close to 92 elements which occur on the earth. The periodic table, as we all know, has close to some 113, as last I remember, close to 113 elements, whereas the human body itself is a periodic table close to having 92 elements. Oxygen takes up close to 65% of it. I'm sorry, I meant to say 26 elements make up the human body. Oxygen, which makes up close to 65%. Hydrogen, on the other hand, contributes to 9.5% of the total. This is a rough approximation. You can't ask me to prove it. This is a rough approximation that it contributes close to 9.5% of the human body mass. Now, let us for a moment ignore all the other elements except hydrogen. Now, why we need to do this is because this has a single proton or a single charged nucleus or a single charged atom, and the spin that it generates or the magnetic field that it generates around it is called as a wobble or a magnetic spin. Then why don't we all act like magnets? This is because of the chaos that I said. All of them are turning around in their own directions and generating a field around them in a haphazard way. Everything is in chaos. Then how do we discipline them? We introduce an external magnet. If you all see, the external magnet is, for example, the machine that we use. It's either a 3 Tesla MRI, or a 1.5 Tesla MRI, or an earlier 0.3 Tesla MRI, or the latest 7 Tesla MRI. All of them are external magnets which discipline the hydrogen atoms. This external MRI strength is called as an external field or B naught. Just as a compass aligns these atoms, each of these atoms align in a parallel direction to the field. Now, for example, in this picture, this atom, the third atom, this atom are all in direction of the field, which is called as in resonance. There are a few which are always rebellious, just like Amir Khan, who are against the field. These are called out of resonance. The amount of atoms which are in resonance minus the amount of atoms which are out of resonance generates the net vector. as to which direction the tissue is generating a vector. If we all have played a top when we were kids, when we give a spin to a top, we call it a bugri in Kannada. When we give a spin to a top, initially it doesn't stand upright. If all of you know, it initially tilts around an axis and then begins to stand up. That angle is called as the angle of precession, and from which it tilts back towards the axis is called as how much is this concept is very, very important. Why? I'll tell you later. Even though it is rotating around its own self, it is also rotating around a central axis. This axis, for example, just like the earth, is called as the angle of precession. Please, you don't have to bother about this, and throughout my lecture I'll be telling you what to concentrate and what not to concentrate. This is a slide which you don't have to concentrate, but just know that there is something called as a Larmor equation, which is necessary for further different types of the MRI sequences, especially MRS. Know that there is something called as a Lenz's law and Larmor equation. Just know the names. Now, when we have a child playing in a swing, now if we push the child, when the swing is here, the swing might go all the way up till here. If we push the child when the swing is here, the arc generated will be even more. Now, this push is called as a radio frequency pulse, which pushes the aligned hydrogen atoms to a higher energy. You are basically giving the hydrogen atoms in the body a higher energy. Now, what happens now basically when we turn on and turn off the radio? Now, as I said, basically don't worry about this again. I'll explain it to you again. Basically understand this, a simple concept. Yeah, we have a block of tissue in which the atoms are all aligned in different directions, and we then introduce an external magnet with a magnetic field B0, either like I said, a 1.5 Tesla magnet, 3 Tesla magnet, whatnot. Then all of them are aligned in a direction parallel to it. Then what happens is when we introduce a radio frequency pulse, this is the tuck, 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 tuck sound that we hear in the MRI. When we introduce a pulse, the energy of the protons becomes so high that they go into a perpendicular direction. They begin to go into a spin, and when they begin to come back, when they shift towards from the angle of precession to come back, this movement is what generates a signal, a current. This current is what is picked up on the MRI coil or the electric coil. This is the concept of MRI. This slide is the concept of MRI. Basically, we turn on and turn off the radio frequency pulse. The magnet, remember, is always there. The magnet is not turned on or off. It is the radio frequency pulse that is turned on or off. That is the sound that we hear. Remember, again, based on the sound sequence, when you yourself sit in an MRI, please, I urge all of you, go into an MRI room, not into the console, go into the MRI machine, hear that sound, tuck, 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 tuck. If it is coming so slow, it is usually T1. If it is coming like tuck, 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 it is usually T2. We are basically switching on and switching off the radio frequency pulse. Based on the magnetic, this is called as the time to echo, which I'll be discussing. Based on the strength of the magnet, we'll be able to better differentiate the tissues. How and why, I'll be explaining it later. This, for example, is a 1.5 Tesla image. This, for example, is a 3 Tesla image. Look at the quality of the vessels when it is a 7 Tesla MRI. 7 Tesla MRI is not yet clinically approved. This is a picture of a rat brain from a 7 Tesla MRI. Look at the finesse, look at the beauty of the cerebral architecture. You'll be able to even appreciate the small folia, the small dentate nuclei so beautifully in the rat brain. Now, how when we give that pulse, the time taken for the atoms to come back initially is called the time to relaxation, or the TR. And T2 or T1 relaxation time, called the spin lattice time. Basically, you don't have to bother about this. T2 is the time taken for 63% of the protons to become dephased. I'll be explaining it again later. Now remember just this. This is a radio frequency pulse. Tuck. This is the electric signal that is recorded. This is the next electrofrequency pulse. Tuck, that sound that comes. If this is very fast, this is called as the time to repetition. Tuck, 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 that is the time to repetition between the two 90-degree pulses. Time to echo is the time taken from the introduction of the pulse to the generation of the current, which is recorded. How fast the current is recorded, how fast the this thing is going, a radio frequency pulse is going, is what determines TR and TE. Remember, I request all of you to know the TR and TE, see the TR and TE in each MRI film that you get. Each one of them is given the TR and TE. Do not go just by the just by that famous sequences that CSF is white, bone is dark, blah blah blah, all that. Okay, in T1 weighted images, TR and TE are very short. They'll be in hundreds. In T2, the TR will be very long. It will be more than 2. It will be in thousands. Now, how does the machine differentiate each atom that comes back? Say, for example, from the nail, the tissue that is coming, the electric signal that is coming from the nail may take some time, whereas the electric signal that is coming from the subcutaneous tissue might take some time. That is how the current, based on how long it takes for the current to come, that is how the machine will be able to differentiate different tissues in the body. That is called as automated tissue contrast. Again, as I said, remember just the upper part of this. T1, in T1 weighted images, TR is short, TE is short. Basically, T1, it is in hundreds, T2, it will be in thousands. What happens, basically, again, what is a T1 weighted image? What happens, what will be dark? Usually CSF will be dark, remember. Again, the best way to remember this, the simple way to remember, you can take a slideshot of this. You all know this. This is another exam question. What is bright on T1? Remember, they ask you these questions very, very commonly. What is bright on T1? Fat is bright, hemorrhage blood is bright, melanin is bright, protein-rich fluids, if it's an abscess or if it's a tubercular abscess, it will be bright. Slow-flowing blood, paramagnetic substances, why I'll tell you later. And copper and manganese will be bright. Why that is, what is the clinical significance of it? Can anybody tell me what is the clinical significance of manganese? Manganese being bright? Anyway, what is the clinical significance? Manganese is because in hepatic encephalopathy, we look at the basal ganglia. T2, again, everything is inverted. The best way to remember for somebody to remember this thing is 2. If you hold your 2 hands as a victory sign and close them, W, it look as W. T2, CSF will appear white. CSF will appear white in T2. What is dark on T2 is ulta. Now, what is star? T2 star or susceptibility imaging? Basically, we look for blood, bone, calcium. All of this which appear dark on T2 star or susceptibility weighted imaging. Okay. Next we have now how do I reduce this? Now, what is this concept of magnetism? Now, each of the tissues have different magnetic susceptibilities. For example, please remember this slide again. It is significant. Diamagnetism, I repeat again, please note this slide again. It's very significant. Diamagnetism is when all of them are aligned in one direction in the opposite direction as to the field given. as to the field given. If the magnet is towards this direction, diamagnets are all towards the opposite. If in paramagnetic substances means all of them are aligned towards the same direction as the field. Ferromagnetic is earlier itself all of them were in the same direction, but they are all aligned in the same field. This is because each of the tissues in the body have different amount of magnetism, which is used to grade the blood. For example, the bleed or the age the bleed. For example, oxyhemoglobin is a diamagnetic substance. Deoxyhemoglobin is, for example, paramagnetic, and gradually you come to hemosiderin, which is super paramagnetic. Based on this, we'll be able to tell what is the age of the bleed. Remember, in a hyperacute bleed, in a hyperacute bleed, it will be T1. T1 will be iso because of oxygenated hemoglobin. In a hyperacute bleed, blood is just coming out of the vessel and spilling in and around in the parenchyma, which is fresh blood, which is oxygenated blood, which is a diamagnetic substance, and hence T1 will be iso, but T2 will be hyper. In acute, that blood which stays there is gradually getting degraded. The hemoglobin gradually begins to lose or give out oxygen to become deoxygenated. And from there, early subacute is when it gets when the hemoglobin becomes methylated to become methemoglobin, and then it begins to become hemosiderin, which is later engulfed by the macrophages to become hemichromes. Okay, so this is how it should normally appear, and hence that is how initially, please, if at all anybody asks you what is the sequence you want to see for aging a bleed, please don't say just T1. You need to see both T1 and T2. In easier way to remember, iso high, or as my friend, one of my juniors used to say, nil high, high low, high, or nil low. You can remember this. Nil high, low, high, nil low. You can remember like that. Now, how does the body, again, this slide is not important. You don't have to give a damn about this slide. I just wanted you to know these terms specifically. From now on, it is sufficient if you know these terms from this slide onwards. You need to know from where, how does the machine know from where the signal is coming from? The machine is just receiving electrical signal from various tissues. How does it know from which part it is coming from? For this, you need to understand that there is a concept called K-space, where it is encoded in the machine in the form of data, which is then restructured, and this is called Fourier transformation, which is not required. You just remember the word K-space. This is a very important slide. Can anybody tell me what I'm going to, what I'll be presenting next based on the this thing, based on the image? I don't know. Anyway, I don't know if there are any guesses, but anyway, when the race begins, the rabbit is going to rush through all the way. Suddenly, in between, the turtle is still here, and we are immediately going to tell, no, the rules have changed. You need to run backwards. All of a sudden, the rabbit is the one that is going to win. This is the concept of invert recover, the concept of inversion recovery. You have given the pulse, you have started the race. All of them are already, all the magnetic, all the atoms in the body, all the tissues in the body are in alignment, and they are about to produce a signal. When you invert and say that I don't want signal from this is like a young boy who says, I don't want to eat dosa for breakfast today. I want only this. So it's like that. I'll say that the signal that is coming from water, I don't want that signal. I am just going to take the signal coming from the rest of the tissue. So whatever signal that is coming from water will become blank. Anything that looks like water will be blank. So that is the concept of inversion recovery. You just take the signal that you want. How do you know that? For this, you should know how that at what is the T1, T2 of water, so that you will know to stop that signal. This is the concept of inversion recovery. Now, there are various types of inversion recovery. Please remember this. There are examiners who even ask this. There are various types of inversion recovery. First, if you invert only one tissue, like this is called stir. Remember, one tissue stir. One tissue stir. You just invert T1 from 1 and say this is like a fat sat sequences. This is called stir. For neurologist, where is stir required? This is very important. Again, they'll ask you this for spine sequences. Remember, T1 inversion, short T1 inversion, stir image you look for in spine. Next, this is basically to look at marrow edema. This, for example, is a normal T1 image. If until and unless you invert the sequence, you don't see the marrow edema that you can see here. This is a case of carpal tunnel or a wrist, but I'm just giving you an example to look at the marrow edema. This is what is important. This is what we all have heard of. FLAIR, fluid attenuated inversion recovery. In fluid attenuated, you basically nullify the signal that is coming from the CSF. All when you are introduced a magnet, you are hello. Am I okay? Yeah, I'm all good. Okay, we basically nullify the signal that is coming from the CSF. We give the magnet, we give the radio frequency pulse, and the moment the signal is coming, we say, I don't want the signal coming from the CSF. So CSF becomes black. That the rest of the signal is just like that. That is why FLAIR is nothing but T2 image minus the CSF signal. Simple. For example, don't look at the right side of the screen, just look at the left side of the screen. Immediately you feel that as though nothing is, it looks although as though it's clear, but only when you invert the signal, that is when you'll see that there is changes in the parenchyma. This is important. Why? FLAIR sequences are important not just to detect the increased signal, but it is important to know fluid cortex surface. When there are lesions near the surface of the cortex, which is very close to water, that is when this is important. This is you are inverting the signal coming from water, from CSF. What happens when you invert the signal coming from white matter also? You have double inversion, not just CSF, you are inverting white matter also. So now you will see only gray matter, only the gray matter. This is called as double inversion. You are inverting both CSF and white matter. And this is where you want to see the lesions in the cortex. This is especially important for MS patients. This is for example, if we see this, we don't see any image on inversion. On T2, there is something bright. FLAIR, there is something a little this thing, but we don't know the extent. But when we invert it doubly, we also blank the image, a signal coming from white matter, then we see only the gray matter. This is especially needed or being published for DIR is published for MS. Remember these sentences. What is triple inversion? Please don't give a shit about it. It's not needed for this thing. If you invert everything in the brain, you'll have no images left. Anyway, that's not needed for us. Again, gradient echo, don't bother about the physics of it. Remember, gradient echo, forget about gradient echo. Remember just this slide. The best example for a gradient echo sequence is 3D cis or cis 3D or Fiesta. What is the importance of this? What we do here is completely inversion of what I just told you. I just told you that I'm going to completely suppress the signal coming from T2. That is, I'm going to say from the T2, whatever signal is coming from CSF, I'm going to say nothing doing. That is FLAIR. When I say I want everything from the CSF, I love CSF and whatever is happening in the CSF, that is cis 3D. This is completely opposite of FLAIR. When there is if you enhance the signal coming from a single tissue, it is called gradient echo. and it's a heavily T2 weighted image. Now, this is important because of this. We need to see what is happening inside the CSF, in the cisternal portions of the brain. For example, we have the basilar artery here. We have the Meckel's cave here where the trigeminal nerve is exiting. This is important for patients who have, say, for example, an idiopathic intracranial hypertension, in which we look at the horizontal diameter of the expansion of the Meckel's cave. We look at the 7th, 8th nerve. This is the petrous apex. And then we have the 7th, 8th nerve exiting. This is the Ica loop. This is the Dorellos canal for the exit of the 6th nerve. So many things we see. But again, please understand, this is to look at not just the, when they ask you what is CIS3D required for, it is to look at the cisternal portions of the cranial nerves only. It doesn't mean that you can look at the cranial nerves all throughout. It is only to look at the cisternal portions when they are merged in the CSF or bathed in the CSF. Just to say, for an example, we have this flare image. We all know that this is a CSF dense lesion, CSF dense hypodense lesion on the flare image, which right now on T2 will appear much bigger, but it still looks like just like a, if we give us this as a differential diagnosis, most of us will say enlarged VR space probably. But why CIS3D is required is to see what is inside it. When we see what is inside it, we can see the scoliosis, and we also can see that there are multiple other lesions which are there in the CSF. This is a racemose NCC, not a racemose, probably a NCC which is becoming racemose. We have lesions elsewhere also. This is the importance of CIS3D, to look at granulomas. Remember, if anybody asks you what is the sequence to look at neurocysticercosis, please tell 3D cyst. Then now, this is by far the topic that I love. What is diffusion weighted imaging? Now, diffusion weighted imaging is another example of a gradient echo pulse, where basically we are looking at how the water molecules are able to diffuse. As we all know, extracellular fluid is the intracellular fluid also has water, just like the extracellular fluid. We are looking at the signals coming from the hydrogen molecules or the water molecules in the inside, which is intracellular. Now, if there is a lesion, if there is a stroke, what happens? Initially, there is this basically stroke means that there is no oxygen or there is no glucose that is coming. Hence, immediately there is energy failure. When there is energy failure, the mitochondria fails. When the mitochondria fails, there is no sodium potassium pump happening. When the sodium potassium pump doesn't work, there is going to be cellular edema. The sodium is going to stay inside, the potassium is going to stay outside. And once the sodium stays inside, the cell begins to swell. This is the concept of stroke, the cellular damage that happens in stroke. Once the edema, once the water that comes and gets retained intracellularly, it's not allowed to move out because of the membrane structure. Because of that, the water molecules are restricted from moving about freely inside the extracellular space. The cells become closely packed to one another. This is the concept of diffusion restriction. Stationary water molecules which are unaffected by the paired, basically they retain their signals, is called bright, and what has a loss appears dark. This is one thing. Again, this is another slide which is very important. They'll ask you what are the differential diagnosis for diffusion weighted lesions, which other than stroke, abscess, demyelination, tumors, any encephalopathic process, CJD, anything. And one more, T2 shine through. You can't say, if you have seen diffusion weighted imaging, you can't say that everything which appears bright on diffusion is a stroke or a diffusion restriction. Please look at the T2 levels, the TE and the TR. This is again very important. What is ADC? apparent diffusion coefficient. This basically looks at the diffusion restriction that is happening at different layers. Now, how do we calculate a particular ADC value? ADC is based on the this is just for just to make sure you know it. It is based on the negative algorithm of the ratio of two image sets. I have one image set with diffusion restriction and that which is without diffusion. Okay. Now, if I take this area, the restricted diffusion signal from T2 is the signal is 10. From the same area, DWI has an image which is say 5. Okay, the DWI gives a signal which is 5. So the ratio is 5 by 10, which is half, 0.5. Negative algorithm will be 0.7. This is the ADC value. Hence, now on the other hand, there is another lesion here. This has it appears same on flare. The signal looks similar, both yellow and red, both have 10. But on diffusion, it appears much less brighter compared to the other yellow area. The signal coming from there is only 2. So the ratio will become 2 by 10 or 0.2. The negative algorithm will be 1.6. So this will appear darker and that will appear much brighter on ADC. This is the importance of ADC. This tells us the age of the infarct. Okay, hence in stroke, the brighter it is on diffusion, darker it is on ADC. Anyway, this is what happens for different signal intensities. What are the diffusion restricting lesions that I told you, and what happens and what is the cause for it. Now, what is MRS? This is what I said, the Larmor equation is important to understand what happens, what is the chemical structure of each tissue. Each tissue, say for example, is made up of different elements. Say for example, there is an abscess. There is an abscess which is forming in the brain. The abscess is basically nothing but necrotic material. The necrotic material which has a lot of cellular debris, and we have the normal brain which is surrounding it. Each of them will have a different chemical structure based on which we can decide what each substance or what each tissue is made up of. This is the concept of MRS, magnetic resonance spectroscopy. Based on the different, that is because each element has a different Larmor signature. Please understand, this is another exam question. There are two types of MRS, a single volume MRS and a multi-volume MRS. This is another single voxel MRS, multi-voxel MRS. Single voxel is where you look at only a slice of tissue. You are looking at just one point. This is like our news media, who just focus on only one point, what is needed for them. They don't give a shit about what is happening around them. This is the typical single voxel MRS. This angle that we see here, this angle is what is called as the Hunter's angle. This is supposed to always be acute. Remember, this is the largest peak that you see is usually of blue, or the NAA peak, which is the tallest peak. Again, nobody is going to, even though I know I can understand that concept of ppm, nobody is going to ask you the value for it. But remember, the tallest peak is NAA, and Hunter's angle is always acute normally. Multi-voxel MRS is like the BBC or the other news channels that I like is something like WION, all of which focus on a broader perspective. They look at all of them together and then take a call as to what is happening to the Hunter's angle in each voxel. This is called as a multi-voxel MRI, multi-voxel MRS. Okay. Now, each of them have different causes. For example, we have a increased, why will the lipid and lactate have a peak? Why does that increase? For example, we have the cellular membrane is as we all know from the Singer-Nicholson model, that the cell membrane is a lipid bilayered membrane. And if that begins to there is increase in the amount of lipids, increase in the amount of the membrane formation, then obviously the signal coming from that particular area will be more. That is called as the increased signal from the lipid tissue. Why does that happen? When there is damage to the membranes, or if there is more and more high-grade neoplasia, high turnover. Lactate happens when there is anaerobic metabolism. When there is anaerobic metabolism, for example, there is hypoxia, when there is stroke, the Krebs cycle doesn't happen. The cycle immediately shifts towards anaerobic glycosylation and begins to have necrosis, for example, in mitochondria, wherever there is anaerobic metabolism or there is no oxygen supply. NAA is a non-specific neuronal marker, but again, just for your reference, remember it occurs at 2 parts per million, ppm. NAA is decreased in neuronal loss. Remember, there are people who ask you what are the MRI markers of Alzheimer's or dementia. Remember, you can use NAA as this thing. Creatine again is a tumor trauma, and this thing. A choline again is a marker for high-grade tumors. This is the concept of there is metabolite ratios basically you use, but remember again, Hunter's angle, NAA peak is the largest at 2 ppm. Now, I will go very quickly through how do we generate contrast. Sir, I'll finish these very quickly. Now, if you look at this, all of them look alike. Sir, I hope I'm not wasting anybody's time. I'll finish. Yeah, everything looks alike. How do we differentiate all of them? This we use a concept called magnetization transfer. Magnetization transfer is important to look at CSF, look at the CSF structures, not just around the CSF, we look at the borders of it. For example, this is a normal gradient echo sequence or without magnetization transfer. This is with magnetization transfer. Again, remember, just know the concept that magnetization transfer is to look at CSF and its edges. Then you have, this is another very, very, very important upcoming topic. This you should know. When you are faced in such a situation, where do you go? Do you take this road when there is a monster, or where you take this road where there is no resistance? So obviously you go to this path where there is least resistance. This is what even normal atoms and normal molecules do. This is the concept of anisotropic diffusion. When you have a tube, you leave a water molecule here, the water molecule comes all the way here and it bounces all the way. Now what happens is, if the water molecule bounces all the way between two membranes and comes like this, now if supposedly there is these two membranes are absent, if suppose the area that the water molecule is bouncing, that is the only thing we look at. This is the small area in which the water molecule is bouncing. You look at that one molecule and where it is going. It goes through a very small slit. The area which it travels is very small. This is called fractional anisotropy. Whereas if these two membranes are absent, this can travel across a wide area. This can, if the road is big, you can drift over a wide area. You don't have to go in a narrow lane. People in Bangalore can understand if the traffic is narrow, you can't shift the lanes. If people in Hyderabad, probably Shailesh sir can understand, if the roads are wide, you can travel, shift easily. You can easily move about. There is easy diffusion. This based on where the water molecule goes or where that particular signal goes, you can track that. And based on that, you use something called as DTR or diffusion tensor imaging. Diffusion tensor imaging, where you say, for example, you say you mark this water molecule with red and this water molecule with yellow, and you look at different ways in which they travel. This is called fractional anisotropy, and you look at where these water molecules are traveling. This is the concept of diffusion tensor imaging, where you will be able to track the water molecules. This is the concept of diffusion tensor imaging, to look at the plexus. Say, for example, there is a lesion here. which is 8 days. You don't know what, if the patient attender comes and asks you what is happening to the, sir, I don't know, can you tell me the prognosis, what is happening? You look at, do a DTI if at all, look at the pyramidal tracts alone. You're looking at the pyramidal tracts alone. Here you can see that there is significant loss of pyramidal tracts in this region where the pons is forming. When this is a pontine, in fact, you can tell them that there is significant loss of the pyramidal tract, and you can quantitatively assess that the pyramidal weakness is more. Whenever there is a bunch of, it's very easy to say, to track an out of place person, isn't it? We all have that eccentric fellow. Just like the one in Three Idiots where Amir Khan say he'll be looking at this thing, he'll be asking weird questions. You just look at him. Do you look at Madhavan or do you look at Raju Rastogi? You don't. You just look at, you go to the movie to look at Amir Khan. This is the concept of MR angio. Please remember, what we do is we look at one RBC and where it is going. Based on that, you once you know where the RBC is going, you look at, you will be able to trace its path and create an image out of it. Phase contrast again is not important. Contrast MRI again, you can leave it. Dynamic susceptibility contrast is another, again, this is another important question where it basically looks at perfusion scans which measures the passage of a non-diffusible contrast through the brain. This cannot diffuse into tissues. If it diffuses through the tissues, then that means that either there is a breakage in the blood-brain barrier. Next, yeah, this is another important concept called arterial spin labeling, which is very close to what I just said. You basically tag, or you just say to a few bunch of vessels which are going near the neck, RBCs which are going in the carotid artery, you tell them, I am going to tag you and I am going to see where you are going. This is like if you enter a museum, or if you enter a particular this thing, they put an RD tag on you and they keep a watch on where you go. That is what is happening. You tag the particular RBC and look at where it goes. And based on where it goes, you look and create an image that tells you how much or where the RBCs are flowing. This is called as arterial spin labeling. Then we have multiple dynamic contrast. This is very important. Please remember, again, this is another very important question that they ask. Dynamic contrast, not simple contrast. This is not dynamic MRI. Dynamic contrast MRI. You dynamic MRI, you look for inflection extension, for Hirayama, for whatnot. Contrast MRI is the normal that you do. Dynamic contrast, you give the contrast and then you move and see very quickly as to how the contrast is happening at one particular sequence. This tells you, especially this is done for pituitary lesions. For example, at 15 seconds, the contrast uptake may be nil. But at 90 seconds, there are regions which don't take up contrast, which tell you that there is a lesion there. That shows you that you need to look at the same place and keep watching them, especially when you're suspecting a highly vascular lesions or in places where contrast can cause blurring of what we want to see. Then, of course, we need to know functional MRI. What is the concept of functional MRI? Basically, the more you function, the more oxygen you need, the more blood flow you need, the more functioning tissues will, where the vessel expands more, the more oxygen is delivered, the more metabolically active. This is called blood oxygen level dependent or bold MRI. This you based on, you tag the oxygen and you look at oxygen, where it is going. All the way you look at how much of oxygen is being used, and if more and more oxygen is being used, that means that area is more metabolically active. For example, if I give you an image and I tell you, and I do a functional MRI and I give you a picture of your girlfriend and tell you, look, if you're looking at a picture of your girlfriend, your this thing is occipital lobe is getting activated, that area will have hypermetabolism and that area will appear will be more active or receive more oxygen. That is the concept of functional MRI. This is the last point that I'm going to tell you. What is MP range? basically understand MP range is where another concept of 3D contrast enhanced MRI, in which we basically look at the vessel wall, intravascular signal, how the intravascular structures. When we basically inject contrast, it travels through the vessels itself. The vessel, the contrast is traveling inside the vessel, but we don't know what is happening to the vessel wall. What if the vessel wall itself is the main pathology in diseases like vasculitis? And for example, in this condition, this is a normal TOF MRI, where we know that this is a hypoplastic one. What if, how would you, if somebody tells you, how do you differentiate that this is not a stenosis or a venous stenosis, or this is not a, how do you say it is a hypoplasia versus a stenosis? When you do an MP range, if the vessel wall, if the flow gap in the left transverse sinus shows, clearly demonstrates the intravascular enhancement of a hypoplastic vessel, this can be, this is what is needed to look at the, for vasculitis and for to detect like hypoplastic tissues. CSF flow studies is for studies like NPH, when there is decreased flow, or in patients like, for example, in hydrocephalus. Actually, this is a video which I'm sorry I cannot play. My transfer, again, this will be too much. Neurography is the last one important thing, to look at the plexus. This is a favorite topic of Khadilkar sir, basically where you look at neurography, where you look at thickened nerves, and to look at the where the plexus are, how the plexus is happening. You basically track. This is a form of diffusion tensor imaging where you track the nerves after they come out of the cord. This again is visual enhancement. So yeah. Basically, thank you. I finished it quick, I hope.
Yeah, thank you, Dr. Murali, SUHAS Murali ji, for in very in very small time you have covered multiple things. If anybody having any question, they can ask. They can unmute themselves and then they can ask directly.